Thank you. That's a very thorough introduction. I have changed the title a little bit because I want to highlight the adaptation part of this intervention. Because some of you might have heard about the presentation from Dr. Zhang Ye the other day about the pay-forward model to improve hepatitis testing. So I want to share the experiences of adapting the model and evaluating the effectiveness of the model in improving HPV vaccine among a completely different population in China, i.e. the 15 to 18-year-old girls in China. Next. Should I click myself, or how should I control my slides? A little bit background. So globally, over 15% of the cervical cancer-related deaths occurred in China. And however, over less than 2% of the priority population, the 9 to 14-year-old girls, received vaccination, HPV vaccination. And this was around 10% for the 15 to 24-year-old catch-up age groups. And in China, there's actually quite high awareness and demand for HPV vaccination, particularly the non-covalent HPV vaccine. But there's a severe insufficient supply. There's relatively good supply of domestically made bivalent HPV vaccine, but the uptake is quite limited. And reasons are probably related to limited public funding for HPV vaccination. There's some local governments piloting the government-supported subsidized HPV vaccination for girls aged 13 to 14-year-old girls, but the scale is quite limited in a few economically developed cities. And also there's a lack of appropriate community-engaged messages or campaigns to promote HPV vaccination for priority populations. And there's also a vaccine hesitancy issue. The vaccine hesitancy is defined as a refusal or delayed use of vaccines available in the market. So in particularly, in this case, it refers to available domestically made bivalent HPV vaccines in the Chinese context. So as I just mentioned, the vaccine hesitancy is defined as the delayed use of available vaccines in the market. So basically, the delay part, like from across the vaccine hesitancy continuum, the delaying behavior is lying in the middle of the continuum. So I would say it's also a type of form of vaccine hesitancy. And before we start piloting or start doing this trial to evaluate this model and see whether it actually works, we did a little bit pilot to understand the context a little bit better. And we did this survey with 100 caregivers, and we found that in the context, in the case of a shortage of non-covalent HPV vaccine, what the caregivers might do when they face this problem. And we found that over 70% of the caregivers chose to delay and wait for the unavailable non-covalent HPV vaccine in the market. So basically, there's a little bit different concept, but still there's a delay of use of available vaccine confidence. So essentially, it's still a vaccine hesitancy issue. So the problem here we identified is the vaccine delay. And the solution we propose or we're trying to use is to adapt the pay-forward model to kind of help solve this problem partially. And basically, pay-forward gives a person a subsidized services as a gift, and also an opportunity to have them voluntarily donate to support other people. So in this case, we offer participants a HPV vaccine, subsidized HPV vaccine, 1 dose And then if they decide to receive it, we invite and ask them whether they're willing to donate to support the initial, donate to the initial pool of fund so that we can use the fund to support more participants to receive the same service. So I have summarized some key features of this model. So basically, there are 4 key components that I think might be relevant to this model. The first is the financial component, because we provide a small subsidy to support participants, which is equivalent to the price of 1 dose of bivalent HPV vaccine in China. And then there is this kindness and generosity component, because communities have an opportunity to donate and support others. And then there is a postcard component, because we use the postcard as a mechanism to visualize the generosity and kindness, so that people get a message, handwritten message, and know that there are people caring about them. And the last component is the community engagement, because we invite them to write postcard messages for others. So it's more interactive and more tangible in terms of passing the community care. So we have a lot of experiences of using Pay It Forward in other settings, like improving gonorrhea and chlamydia testing among MSM population in China. And it worked really well. And we also used it in flu vaccination promotion. And the results turns to be pretty much the same, because we significantly improved the influenza vaccination among both children and elderly people. So I just took it for granted that this model will definitely work among the HPV vaccination setting for middle school age girls. But the pilot result turns to be not working so well, and I will explain why. And basically, the overview of the formative research to adapt the model is that we conducted a feasibility pilot study to test the process and preliminary effectiveness. And then we conducted this focus group discussion with the caregiver participants, and to understand why they're taking this or why they're not taking the HPV vaccine under the Pay It Forward condition. And then we also co-designed these intervention materials, including the postcards and messages that they want to see through the intervention arm. So we conducted this pilot testing during 3 or 4 month period, and we tested the feasibility, the context, acceptability, refinement, strategies, and we also figured some systematic and organizational context, like whether how available the vaccines are and what types of vaccines that may be more stably supplied at the community setting. And we test out the user journey and figure out the implementation barriers for the Pay It Forward implementation. And these are the initial batch of postcard messages that we have designed. So these are designed by college students. So the messages are pretty succinct and simple. So we try to promote the idea of early vaccination. So the Chinese reads as cervical cancer by far is one of the only vaccine preventable cancers in the world. And we try to encourage them to vaccinate as early as possible so that we can get the best protection effects against cervical cancer. However, the results turns to be that in the standard of care arm, we have an uptake rate of 82%. And although the Pay It Forward has significantly better by increase of 16%, but still having such a high uptake rate in the standard of care condition is already pretty excellent. So it's good. It's just making the good to excellent. So it's like 82% is already an optimal kind of uptake rate. So we're trying to figure out why, and we think and reflected about the implementation process, because we did what we have done for our previous pay-forward trials, like we, in the previous trials, we did some online promotion of the trial, and we provided services at the clinic, and we figured that this online promotion caused a serious selection bias. We use this promotion strategy because it's what the clinic has been done. So we thought that it might be the good strategy to go for promotion of this or for recruiting participants, because it's a routine. And it's convenient to do this. However, the selection bias is pretty bad. And also the vaccine availability, we provided what was available at the moment at the piloting clinic, so which are bivalent and non-valent HPV vaccines at the specific period of pilot. But the actual problem is that the non-valent and quadrivalent vaccines are out of stock for most of the time at most of the clinics. And so the challenge we identify is through the pilot is the delayed use, as I just mentioned, for the problem. So we refine the recruitment strategy by doing a random sampling through the residency registration system, which is the name list, and then we did a random sampling through the population-based method. And we provided the most affordable and available HPV vaccines in our formal trial, which is the domestically made bivalent HPV vaccine. But many of the providers have been saying that this is super hard to promote this domestically bivalent HPV vaccine. So this is the problem that we are trying to solve in this trial. And these are the refined postcard messages after discussing with the caregivers what they want to see and how they want the postcard to be designed, etc. So we identified the key knowledge gaps among the caregivers. Say they don't really understand, they may be aware of the vaccines, but they don't know the exact differences between the bivalent, non-valent, or quadrivalent vaccines. So we deliver the key messages. All these messages are designed based on the scientific base. We find this evidence from the published evidence. And the first postcard focused on different types, and the second focused on the emphasis of the age of vaccination. So the earlier, the better protection effects you get. Once you get at 12 to 13, you get like maybe 85 or even higher protection effects. But when it goes to 16 to 18, you may get only like 34% protection against cervical cancer. And the last postcard focused on age of sexual debut. So the formal trial, we did this, is quite small, hard to read. So we did this population-based sampling, and we made thousands of calls to participants we identified through the name list, and eventually 321 participants were recruited, and we randomly allocate them into standard of care group, which is the self-pay vaccination, and then half of them to the pay-for arm, which offers the opportunity for them to receive a subsidized vaccine, and then they're also invited to write postcard messages and donate. So the results here, so looking at the right hand of the slides, the actual vaccine uptake we have found is that in the standard of care arm, we had only 17.5% of vaccine uptake, and this was nearly double of the vaccine uptake in the pay-for arm. So I think this is sort of reflecting the actual situation in China. And the pay-for was significantly improved. And the vaccine uptake rate by study site and by sex of the guardian, we have pretty good effectiveness among subgroups as well. It worked really well among female participants and much better, probably much better among the lower income groups by the pay-it-forward effectiveness. And also education level, different education level groups and different study sites participants, they all seem to be working really well. And also the second outcome that we have looked at are HPV vaccine confidence. So basically these are the three most commonly used vaccine confidence variables. So the confidence in vaccine importance and safety and effectiveness and pay-it-forward seem to have significantly improved all domains of the vaccine confidence, except one on the bivalent HPV vaccine importance. It still has a positive impact, but it's statistically not significant only. And then the intention to delay component, it also significantly reduced the intention to delay among the pay-it-forward participants by 15%. This is pretty consistent with the increased level for the vaccine uptake. And in terms of the kindness and paying forward, among the 55 participants who vaccinated, 39 of them donated, and we collected total donation of $332 US, and this accounts for around 12.6% of the subsidies we provided to pay-it-forward participants. And really amazing community engagement and writing postcards, messages for others. And these are mostly done by the girls when they are waiting, after they receive the vaccination and waiting to be observed for side effects in the clinic. And donation by study site, we observed significantly better donation among the higher income, among the participants from the higher income regions, because we have these 4 study sites from different economic level regions, and these are significantly better among the higher income higher income regions. And it's not really surprising because that's what we expected actually. And in terms of the cost analysis, the pay-it-forward arm has significantly lower financial and economic cost per person vaccinated compared to the standard of care arm. And there's some more results about the economic and financial costs results. So in summary, the pay-it-forward model, the adapted pay-it-forward model for addressing this HPV vaccine hesitancy and low vaccine uptake rate, is pretty good. And so basically we observed really good or increased HPV vaccination uptake rates and really good generosity, community donations, and co-created messages. We also identified some challenges for implementation, but I think these are good information for improving the future implementation for future scale up as well. And our next phase of the study will be trying to think of ways to scale this up within the school settings or within the clinic settings. So the final thing I would like to ask the audience from the room to be generous and think of ways to pay forward. And this model is totally adaptable, and we should make this kindness contagious within the community. Thank you for your attention.